Now, I'd like to turn it over to JC Cooper, Director of the State Demonstrations Group at CMS. JC, you now have the floor.
Thank you so much. And good morning or afternoon, depending on where you are. Really just want to welcome you to today's webinar around states' experiences in cross-sector and cross-agency data sharing for 1115 demonstrations. I think we can all agree a very critical conversation to achieve, I think, the amazing outcomes everybody is hoping to achieve through these demonstrations. And CMS is really thrilled to provide a platform to highlight state efforts to improve data sharing for these demonstrations and appreciate our speakers from both North Carolina and Oregon to share in their experience as they've gone through this journey. And we really hope today's webinar is informative, and we appreciate your participation and partnership with CMS along the way. Next slide. So we have a great agenda put together for you today, really highlighting two states and their experience with data sharing. North Carolina will present on implementing its standardized screening tool for health-related social needs and leveraging data for their evaluation. And I was lucky enough to be in Nashville this week, where I also heard North Carolina speaking with other states on this, and just such valuable learnings to share across the board. We also will have Oregon present on challenges and experiences with data sharing efforts within their state, and lots to learn there as they have been doing a lot of work here as well. So between the state presentations, attendees will also be able to enter into breakout rooms to discuss data sharing experiences. One of our big feedbacks that we had from our previous discussion was really allowing for that state-to-state conversation in breakout rooms. And so hopefully this will be a great new addition to our Learning Collaborative meetings. Next slide. So, as we really dig in, data sharing has numerous benefits for several stakeholders. For beneficiaries, it helps support the receipt of seamless and comprehensive and appropriate level of care across the care continuum. So just the value for beneficiaries as data sharing improves in the coming years, we just think is just so critical to meeting the outcomes that we all hope to achieve. It also increases the data that's being collected, reduces staff burden through the ongoing communication and collaborating across partners. A lot of the stuff we're talking about today, whether it's health-related social needs, reentry, SMI or SUD services, you're partnering across the full healthcare landscape, and data sharing really fosters relationships and across sectors and agencies is just so critical to be successful. Also, existing data sharing initiatives and infrastructure can really be leveraged for future initiatives. And so building a solid foundation now really just behooves us as we continue to find ways to coordinate across so many systems and partners. Data sharing efforts really enable states and Medicaid agencies to answer key questions about the populations they serve also, which can really support the ability to identify unmet needs and identify potential solutions for populations. Really leading to improved outcomes for our beneficiaries across the greater healthcare system. And so we know and see where data sharing happen, how it can really improve, better identify what the gaps are, better inform where we go as agencies and partners to move the needle here. In late August, CMS also published a health affairs article, which really summarizes takeaways from interviews across hundreds of experts, including those represented in the health information exchanges, data aggregators, data vendors, model participants, and just a number of people weighing in on this. And the article really highlights data sharing principles that the CMS Innovation Center developed, really based on all of those interviews. We hope you check it out. We'll make sure it's sent out in any follow-up items and linked in all of our materials. Data sharing can just be a powerful tool that we all use. And so look forward to the conversation today. Next slide. We also know that states implementing our substance use disorder and SMI SED demonstration components have shared data across entities to support implementation, monitoring, and evaluation. And those demonstration components really aim to improve access to services and care coordination. And we know data sharing is at the core of being able to achieve those streamlined referrals and improved care coordination for our patients. Additionally, the demonstrations increase in size and scope. The need for data sharing is just even more important, and it's beyond just provider to provider data sharing, as many of us know. States are really implementing health-related social needs, the reentry and justice involved demonstrations, and really cutting across various demonstrations. So today is not just focused on data sharing within one type of demonstration. We're really showing about how demonstrations are moving to multiple state agencies, partnerships, whether it's coordinating housing and nutrition supports, or whether it's working with our correctional partners in reentry, as well as connecting with those various behavioral health services. And so I think the timing is right in regards to the conversation that we're having today. We look forward to states sharing and learning from each other as we go through the conversation today. Next slide. And so it's with my pleasure to turn over the presentation to our colleagues in North Carolina. Kristen and Maria will take you through their journey, their learnings with data sharing, and hope everybody enjoys our webinar today. So I will turn it over to the North Carolina team.
Great, thank you so much. I'm Kristen Dubé, Chief of Population Health here at North Carolina Medicaid, and I'll let my colleague Maria introduce herself.
Everyone, I'm Maria Ramirez Perez. I am the Associate Director of Healthy Opportunities with North Carolina Medicaid.
We are really pleased to be with you all today to share a lot of the learnings that we have through our 1115 demonstration waiver and all of the data sharing work that's been going on as part of that. There is just an enormous amount of work, and I just really want to recognize the extraordinary team across the North Carolina Department of Health and Human Services that's been involved in this work, as well as so many community partners and our health plan partners. So just an incredible effort. It's really wonderful to be part of this team. Let's take it to the next slide. So North Carolina is focused on taking steps to ensure all North Carolinians have opportunities for health. So we recognize traditional Medicaid services impact just a small portion of a person's overall health. And so with our 1115 waiver, we really want to test how we can address some of the other 80% of contributing factors. We re-envisioned how we could strategically and pragmatically develop these new innovations to buy health. So what does that mean? As other social and environmental factors continue to accelerate individuals' risks for poor outcomes, the COVID-19 pandemic, increased health disparities, we have rising risk factors for chronic disease, and we continue to see increases in healthcare costs. We wanted to see how we could impact social and environmental factors to improve health. Next slide. So we strategize buying health with a departmental initiative called a Healthy Opportunities Framework. This framework is really meant for all populations in North Carolina. And so we started with a couple broader pieces of that framework. That includes a Healthy Opportunities Hotspot map that breaks our state into regions. We can use that to review various social and economic factors that impact health, and then more closely target interventions to the communities where they're needed most. We developed a standardized social needs questionnaire in collaboration with many community partners, and then we implemented that statewide within both community-based organizations and medical practices, so we can really identify and collect data on social needs related to housing, interpersonal violence, transportation, and food needs. And then through a private-public partnership, we procured a closed-loop referral system so that individuals who are screened for social needs could then be referred to local resources. And then that referring entity would receive that information back regarding whether or not the individual actually made that connection and received the care. Anyone in the state, regardless of healthcare coverage, can be referred into the system based on their needs. Also, we made investments in establishing training and growing our community health worker workforce and really helping individuals access community resources from individuals who know those communities well. And then our framework was also, that framework in particular, the community health worker workforce was extraordinarily valuable, supporting our efforts to roll out COVID-19 isolation and quarantine supports during the pandemic. So that's the broader framework. We took that broader healthy opportunities framework and infrastructure, and then also embedded that into our Medicaid program work. So that serves as the foundation for our quality strategy, which we use to improve our health outcomes. And then our 1115 waiver includes mandatory managed care programs, and their contracts incorporate a variety of healthy opportunities expectations and extensive data sharing requirements so that we can monitor plan performance across the spectrum of service delivery expectations. We also have value-based arrangement expectations with plans and expectations with them regarding providers participating. And that includes member risk stratification, which incorporates that standardized screening questionnaire into requirements as part of that assessment. We also have a care management model across our Medicaid programs to make sure that individuals have person-centered care focused on meeting both their medical and their non-medical needs, and that includes referrals to social determinants of health services. So within that 1115 waiver, and then more narrowly applicable to Medicaid beneficiaries, we also have our healthy opportunities pilots in certain regions of the state. They are an incredible demonstration of how data exchange can really help support improved health and access. But Maria will go into that a little bit later. Next slide. So before we talk about the Healthy Opportunities Pilot, I want to touch a little bit more on the foundational data exchange expectations North Carolina Medicaid established through our 1115 waiver managed care implementation and the innovative strategies we're taking to improve that data exchange across the state. So with the robust care management requirements that we're expecting of all the health plans to ensure our managed care beneficiaries have the support they need to medical and non-medical needs, we make sure that care management is delivered as close to the site of care and in the patient's community as possible. So where we see is the development of care management services. Any provider, primary care provider, who is able to meet those expectations of developing those services and pass a pre-delegation audit was required to be offered a good faith contract from the Medicaid managed care plans. But one of the pieces and components of the requirements providers had to be able to meet in that pre-delegation was the expectation to be able to receive data. Those data include claims, member data, including risk stratification from the plan for those members, and then hospital admission, discharge, and transfer data. Providers were expected to utilize the data that they were receiving and then do their own risk stratification of the members to determine the care management level of care management support they need and also to identify care gaps. The care management teams would conduct risk assessments and develop care plans who need complex case management support, and then offer episodic support for those needing connections to community resources. So all of this work is happening statewide within our managed care system. Those care management entities that are doing that work are then sending data back to the plans. So the data they're sending back includes updated risk stratification information for members. It includes data on care management interactions. The health plans are then consolidating those data with the information that they are collecting from the members that they are serving. So they also have care management engagements with members not served closer to the community, and they're submitting those data back to North Carolina Medicaid through an operational report. Then we can use those to monitor and review statewide interactions. And then before we move on, I want to also touch on the admissions and discharge transfer data requirements and the foundational infrastructure that's been underway in our state to make sure those data would be accessible to care management teams across the state. So most care management teams and the health plans themselves are accessing those ADT data from North Carolina's Health Information Exchange, which we call NC Health Connects. NC Health Connects was established as a result of state legislation that really wanted to have a system where we could securely share health information statewide. In that legislation, it required that all Medicaid and state-funded healthcare providers connect and submit Medicaid data to the HIE. So that system has been extraordinarily helpful in us rolling out these programs. And the system was developed in partnership with a number of different agencies, with particularly the Government Data Analytics Center and SAS Institute. And they really focused on data privacy, interoperability, and making sure we have high quality data in the system. They're integrating those data from a variety, many EHRs and clinical settings. They also have connections with the North Carolina Immunization Registry and our State Lab for Public Health, and then of course with us in North Carolina Medicaid. And then that system, NC Health Connects, can provide a clinical portal for providers who want real-time patient data that may be coming from a different provider's office. And then the NC Notify system is the one that provides that admission, discharge, transfer data. Some providers and plans actually have bidirectional feeds, so they get those data back into their EHR or their care management platforms, within which they're already working, so they can get those notifications in those systems. There are also data extracts for population health analytics that can support the Medicaid health plans and our Division of Public Health programs. So we are continuing to partner with the North Carolina Health Information Exchange at North Carolina Medicaid on some Medicaid enterprise system projects supported through an APD. And those are specifically focused on digital quality measures, getting those in real time, more efforts around sharing of the health-related social needs screening data, and then looking at some additional care management data exchange opportunities. And a few other key priorities for the North Carolina Health Information Exchange include enabling secure exchange of Part 2 data with patient consent. That's being worked on closely. So really, the Department of Health and Human Services, we're dedicated to utilizing data to improve and drive outcomes. It's a key part of our strategy to buy health. It's really that foundation building along all of this data exchange that the Healthy Opportunities pilot was built on top of. So I'll go ahead and pass it off to Maria to share more about Healthy Opportunities pilots.
Thank you, Kristen. So shifting gears a bit, the Healthy Opportunities pilot, as Kristen alluded to, is essentially a program that was authorized on November 1st, 2018 as part of North Carolina's 1115 waiver, and provided the state with authority to use up to $650 million for service delivery and infrastructure development through October 31st of 2024. We are currently in the process of negotiating the next phase of this waiver, which would provide North Carolina to continue the authority to continue providing services with some modifications from November 1, 2024 through October 31st of 2029. Now, for this first phase of the waiver, which we are currently in, I will acknowledge that after some delays, including a global pandemic, North Carolina really worked to use the infrastructure that Kristen spoke to, that really created managed care and really worked to be a part of the broader effort to build health in North Carolina communities and implement these services, which went live on March 15th of 2022 across 33 predominantly rural counties in North Carolina. This was done in a phased approach which consisted of launching each domain, food, housing, transportation, and cross-domain, essentially 6 months apart. The main exception to this was IPV services, which had a delayed launch by approximately a year to allow time for additional security modifications, which included additional training and system development to ensure that data was secure for any members who had an associated IPV case, interpersonal violence case. Now, this is where, after March 15th, this is really where North Carolina began to look at how we would gather data, not just to be able to understand what was happening with the program and where we were tracking towards our goals to improve health outcomes, improve health equity, reduce costs, but also look at how does this infrastructure that we are developing, how is that operating? Is it effective? Where do modifications need to be made? We essentially launched with an approach that prioritized ensuring that we could start from a place that we could build. So we began with a system that we knew may not be perfect, but we knew we could build from that and make the additional modifications needed to ensure, like with IPV, that all appropriate securities could be built into the systems that were being utilized in order to ensure that those services could launch. Next slide. Now, how these pilots are currently working. There are many, many stakeholders. And essentially, each stakeholder, as you see here, is connected with each of the stakeholders where you see a line. There are 8 managed care organizations between what we call standard plans and tailored plans. Tailored plans, in this case, overseeing the managed care for our more sensitive behavioral health and IDD populations. Really, these MCOs, for the purposes of the Healthy Opportunities pilots, are the entities that are approving services and managing the service budgets. This work within the Healthy Opportunities pilots is predominantly done within a single platform of NC Care 360. Everything from the documentation of service authorization to invoice approval is done here. However, payments are completed outside of the NC Care 360 platform. There are also 23 care management entities which participate currently. And these include entities like local health departments, advanced medical homes, or care integration networks. These are the entities that are assessing member eligibility and tracking their progress over time, both clinical and social care needs. This is an area where there is actually a bit of a challenge within Healthy Opportunities in how we utilize data, because while care managers are able to input all Healthy Opportunities pilot related information into NC Care 360, so all information related to a person's social care needs, the connection to the HSO or the entity that will deliver the service, the authorization that goes to the health plan, all of that is managed within one system. However, the care plan is something that is managed externally, and this is an area where we see opportunity to have further integrations down the line to be able to ensure that these are entities that are only having to use a single platform for these various activities. There are also 3 network leads, and these are the entities which are sometimes referred to as care hubs, and they use data from the NC Care 360 platform and data that they gather from their community-based organizations via reporting and monitoring in order to oversee the human service organizations, or HSOs, that form their provider network. They also provide technical assistance, training, and invoice validation. And there are now over 150 human service organizations, which are made up of community-based organizations, local health departments, and entities that collectively are part of their communities, are onboarded as Medicaid providers, contracted with network leads to provide Healthy Opportunities pilot services across the various domains. These entities are onboarded as Medicaid providers through North Carolina's MMIS and C-TRACS, and this allows essentially verification for the health plans to be able to verify that they are paying active Medicaid providers for the provision of approved HOP services. And human service organizations also support HOP enrollment through a no wrong door approach. Next slide, please. Okay. This is more of a summary of what that no wrong door approach looks like, and this is how beneficiaries or members can access pilot services. We really prioritized having a simplified approach for the referral process that prioritized simplicity for the member. So they could pick up the phone and call their health plan or their care manager, or if they're with a provider, that provider could input that information into NC Care 360 and connect them with their health plan, who would conduct the assessment and then reach back out to the member to let them know whether they are eligible or not, and also work with them to assess the service mix. Next slide, please. Another area where we worked to simplify the design and trying to think through how we can centralize all of our data as much as possible is in invoicing and payments. Now, once a person is referred into the Healthy Opportunities pilots, again, following that no wrong door approach, and when services are delivered by a human service organization and that delivery is tracked in NC Care 360, the providers would then need to submit an invoice via this platform. And the goal here is really to try to create a clean and easy process for providers who are not familiar with or experienced with Medicaid claims. and for whom it would be prohibitive to participate in the pilots if they did have to submit claims for processing. And I will say, when we initially launched, that was kind of the foundation we built on. There was an invoice. There was a proprietary file that was sent to the health plans for them to essentially turn those invoices into actual payments that they could make in their systems. What we transitioned into as we continued to evolve the program was building the capability within the NC Care 360 platform for that invoice to be converted into an 837 claim that brought the HOP invoicing process into alignment with the standard Medicaid billing structure, but keeping that simplified invoicing process forward-facing for HSOs. Next slide, please. Now, as I've mentioned NC Care 360 a lot, this is a platform that we've utilized in North Carolina. We really wanted to maintain a consistent standard systems and workflows and responsibilities across entities. And the state made the decision to leverage an existing platform, which was a statewide closed loop referral platform that already was used to make referrals for social care needs. And this was used in order to connect all HOP workflows. So there was additional functionality that had to be developed for eligibility, enrollment, service authorization, and invoicing. And this includes things like invoice disputes and invoice submissions, which are done through the platform. Now, again, we did take the approach of having what we called a base pilot functionality, which leveraged a more manual approach. And again, like with invoices, taking an approach where we had something that was more manual, that required more work of the health plans, but which we were able to simplify and automate over time. And then overall, all processes of the Healthy Opportunities pilots, all the core responsibilities are built into the NC Care 360 platform, but there are additional functions which exist. And so, for example, network leads must use contract management systems because there's additional reporting that HSOs must complete, and they have to be able to track that. Similarly, care managers have to use their own systems in order to track the care plan progress and include the social care needs that are being addressed as part of that. But as Kristen was alluding to, I think there are various strategies that the state is currently exploring about the health information exchange, where we see some opportunity to further improve on this data integration processes. Next slide, please. Now, we have had this program live for several years now, and it's incredibly exciting to have seen the concept of an infrastructure actually go live. But more exciting was in April of this year, there was the release of the interim evaluation report, which really began to show some very promising results. As we see here, for HOP participating individuals, there is a significantly lower health care expenditure with $85 less PMPM after accounting for the HOP service delivery spending, and decreased hospital utilization and decreased inpatient hospitalization for non-pregnant populations when accounting for HOP versus non-HOP beneficiaries. Next slide, please. Now, there are a lot of lessons learned. This is something we could talk about pretty endlessly, quite frankly. And I think some of the keys here that I've alluded to are things like phased implementation, not just for services, but for technology. It was really important in North Carolina that we start somewhere. Again, acknowledge that things may not be exactly perfect, but start somewhere that you can build from and improve, and ensure that there's a way to gather early and frequent feedback from stakeholders that are actually using the workflows and the systems, so that those can be modified as you go. A good example of this is, again, our development of that base pilot functionality, which is now moving into an improved advanced pilot functionality within the platform, where we're able to automate more processes, like having task lists and greater reminders for care managers on the different tasks that they have to do, like reassessments. But there's also, again, that automation for the invoicing. It has also been really important to keep all of the affected data teams. So I will say there's our data teams at Medicaid, there's the data team for the system developer, there's this data team for our evaluator, who all have had to work in really close communication and coordination in order to ensure that they can track how any modification into the platform has resulted in a downstream impact to how that data is being ingested. So this is something where we've had to make changes as we go that were really essential for operations. Again, creating greater automation, but that creates new fields, which creates complexity in how data is ingested. And so it's been really important to have those teams really closely in the loop for how these changes are happening so that they can also keep track of where these changes are happening in the data downstream. This is, again, where it's been really important to have real-time monitoring for the program to be able to inform how we make modifications as we go. And I cannot stress enough the importance of network leads, not just as an entity that is overseeing HSOs, but also as a partner in improving our understanding of data. Data without context has a lot of meanings. And so network leads and those partners that are close to the field have been really important in helping us understand what different data points and patterns mean on a practical level for this program so that we can then actually convert that into changes that we can make. There's also an importance in investing in human service organizations and continuing, I will say this is an ongoing lesson, continuing to work to centralize data so that we can have, for example, greater integration. So we have everything in one place, but all of the different connecting points are there for the other data that needs to be used, like, for example, care managers with their care plan. And then finally, again, the importance of having member engagement always at the forefront, making sure that member experience is being considered always and throughout the process, because at the end of the day, these are the individuals who are receiving these services. And as we are looking at the data, it matters to think about what this means for those individuals that are being served. That is everything from me. I will hand things over to Rivka.
Great. Thank you. Oh, sorry. Thank you so much, Kristen and Maria. I'm Rivka Weiser with Mathematica, the contractor that's supporting CMS on this webinar, and I'll be facilitating the Q&A. So we're now taking questions for the North Carolina presenters. As a reminder, you can use the Slido Q&A panel on the right of your WebEx screen to submit a question. So we have a few questions in already. I'll start there. The first one is, why are the care plans managed outside of NC Care 360?
I'll go ahead and begin the response for that. So we rolled out our new care management programs when we launched Medicaid managed care in 2021. And so at that time, we needed to make sure the care plans were a key part of that care management program. And we had expectations for the primary care providers that were providing that community-based care management service. It was necessary for them to be able to be working closely with the primary care provider on the ground to make sure the care plan was established based on the individual's health goals. And so we wanted to make sure it was really part of that work. That work was also connected with connecting individuals with social determinants of health, and particularly the work with the Healthy Opportunities pilots in those regions. But building it out, we want to be flexible with providers so that they could utilize the systems that worked most effectively for them for the care management tools. So some of them were able to build out those care plans and utilize their existing EHRs. Others were utilizing separate care management systems to track their care management interactions data and report back to the plans. And so in some cases, the care plan needed to be there and then also tagged back to the provider's EHR. So it was really built around that care management model primarily. I'll just pass it off to Maria if you have anything you want to supplement.
I think that's right. From the technical side, I will also add NC Care 360 is not itself a care management platform. It's a referral platform that we built additional functionalities onto in order to be able to address programmatic work streams. So it's very similar to, say, a referral to provide a food box or a referral for an authorization to provide a food box, but it looks very different to actually track progress over time on that type of platform.
Thank you. Another question, the approved invoices, are they paid by the managed care plans or the state?
So the state provides a capped allocation to the health plans for them to make those payments, but it is at no risk to the health plans.
Okay, thank you. We have a few more questions, but I think we'll just go with one more for now in the interest of time. Is what types of investment did North Carolina make in HSO participation and onboarding, and what was the most helpful investment?
There were multiple. I will say there was the investment in having network lead entities. So that was a significant investment in ensuring that there was an entity available that could provide extensive technical assistance, training, and really continues to do a lot of that work. And also an entity that would oversee the continued improvement for community-based organizations. We also provided direct resources through what we call capacity building funds and are sometimes referred to as infrastructure development funds for those organizations to be able to staff or get the appropriate systems that they needed. We are working with organizations that have a wide range of experience levels, so it was important for them to have that funding available up front for them to build up that capacity to be able to begin providing services. Kristen, would you add anything to that?
No, I think you covered it well. Thanks.
Great. Well, thank you for your answers. I know we didn't get to all the questions. Perhaps we'll have more time later on. But for now, we're going to move ahead with our small breakout discussions. So yes, that's a good slide there. This slide covers the next steps and flow related to the breakouts, and then the following slide has more details on what to do in the breakouts. So participants will soon be randomly assigned to small breakout groups in this webinar platform. Note that there's no designated facilitator in each group, it's just randomized participants. Also, please note that the breakout sessions will not be recorded. So you'll have about 15 minutes for the discussion, including brief introductions and then discussion of cross-sector or agency data sharing initiatives that your states implemented or considered. We'd also like to compile brief takeaways from across the breakouts. So when we reconvene, we'll ask a representative from each group to please respond to a poll in WebEx about those takeaways. And then after the next state presentation from Oregon, we'll discuss themes from those takeaways. So next slide, please. All right, so a little bit more specifics about what to do once you're in a breakout room. First, please briefly introduce yourselves, including your state and your role there. And then please select who will write a brief summary, say just about 2 to 3 sentences or so, of key takeaways from your breakout after we reconvene. Then the main part of the discussion focuses on the question of what cross-sector or cross-agency data sharing initiatives has your state implemented or considered. You can consider details related to lessons learned, promising practices, challenges, and how you have addressed those as well. So Derek, can you please assign people to the breakout rooms now? I know that some participants have joined off, so we might need to rejigger the number of rooms that we're doing. Don't forget, everyone, that we will also have the Oregon presentation afterwards. And if you very much don't want to join a breakout room, you don't have to click join now. But once you get a prompt on your screen to join the breakout room, you can click join now to join it, and then we'll reconvene here in about 15 minutes for Oregon's presentation.
Rivka, I will start the breakout rooms, and everyone that will be participating in a breakout room will see that join button. So if everyone please stand by, I'll start our breakout sessions.
Thank you. All right, I think everyone is back now. Derek, would everyone be back automatically in the room right now?
It's going to take a minute with so many folks. So okay. Everyone should have returned.
All right. Well, thank you. Well, welcome back to folks. Thank you so much for participating in the breakout sessions. We hope you found the discussion to be interesting. I invite everyone who was a representative for your group to please go to the Slido poll in the panel on the right of your screen. In that poll, if you could please write down briefly, just maybe 2 to 3 sentences, some key takeaways from your discussion, and we can summarize some themes later on. Next, I'd like to introduce Lisa Parker, Amanda Peden, and Steve Westberg of Oregon for their presentation. Thank you.
Hello, everyone. Good morning / afternoon. And again, my name is Amanda Peden. I use she, her pronouns. I manage an analytics team here at the Oregon Health Authority that's focused on health-related social needs analytics. It's called the Social Health Needs and Analytics Projects Team, or the SHNAP team for short. And I'll be running through our agenda briefly first, and then I'll turn it over to my colleagues to introduce themselves a little bit more. And then we'll get started with our deeper presentation. So next slide. Today, we're going to take you through a quick overview of our Medicaid 1115 demonstration, and we'll focus on 3 areas where we're building infrastructure for cross-sector data sharing, both within and across agencies and in our broader healthcare system. So we'll start with talking about leveraging our closed-loop referral technology in the state, and then we'll talk a little bit about our state's hospital event notification system. And then we'll share the ways we're working to build bidirectional data sharing infrastructure for a future of hopefully smoother data sharing. And we'll close with some lessons we've learned along the way. Next slide. So now I'll turn it over to my colleagues, Lisa and Steve, to introduce themselves. Do you want to go ahead, Lisa?
Sure. I'm Lisa Parker. I use she, her pronouns, and I am the Community Information Exchange Policy and Program Manager in Oregon. And my team does a variety of things, from monitoring national landscape around closed-loop referral technology to looking at statewide policies and efforts to working specifically on helping implement and develop what's needed for our 1115 Medicaid demonstration. Steve?
Hi, everybody. Steve Westberg. I am the Director of Data Strategy and Operations, responsible really at a high level for trying to help de-silo all of our data and better connect our systems. So I'll pass it back to Amanda.
Great, thank you. And finally, I also want to send a quick shout out and thank you to all of the many, many people and organizations within and outside of our state agency who are really working tirelessly to implement Oregon's 1115 Medicaid demonstration, both in health-related social needs service implementation and in other program areas. Next slide. I'm going to pause for a moment on this slide. I know it doesn't say much. I'm going to just share a little bit of context. So before I launch into a brief overview of our current demonstration waiver, I want to share a few background points about Oregon's Medicaid model that give important context to how we approach the work in this state. So Oregon has been operating under our current Medicaid delivery model since 2012, and that's when our unique managed care model, coordinated care organizations launched. And today we'll generally use the term Medicaid managed care entity in this presentation. So as part of this model, we have 16 community-based Medicaid managed care entities operating across our state. And our managed care entities operate with a mix of contractual requirements from the state and also built-in flexibility to allow the plans to really respond to community priorities and needs and to design systems that work best for their communities. This most recent demonstration is the 3rd demonstration under Oregon's model. And so implementation of health-related social needs has involved a lot of work to collaboratively plan and to integrate these new services within existing CCO processes and across varied regional models. And there are a couple of reasons I wanted to call this out before giving the specifics on our demonstration. And one is that we're about to share, what we are about to share are lessons learned in the context of a state where there are fewer opportunities to build a standardized system up front, and a need to really respond to and leverage systems that are in place and in use. And the other reason is that the volume and variety of community-based models across the state really adds more complexity to our data sharing endeavors, especially when we expand beyond data sharing between agencies to sharing across the health system. Next slide. So now I want to give a high-level overview of our current Medicaid demonstration waiver. In Oregon's 2022 to 2027 waiver, or current demonstration, one of the overall goals is that Oregon's Medicaid members who are experiencing certain life transitions will have social supports available to stay healthy during these more challenging times in their lives. And this slide lists out the various approved strategies we're implementing as part of the waiver. There are data sharing opportunities and needs across our current demonstration programs. But today we'll focus on the one that is highlighted here, health-related social needs supports that include housing, nutrition, and climate supports. Next slide. We've already been talking about health-related social needs for much of this waiver. We heard a webinar. We heard a lot of that from North Carolina. So I will just note the definition that Oregon uses on this slide here. And as I mentioned in the prior slide, the specific services covered under Oregon's demonstration include housing supports, nutrition supports, climate-related supports, and also outreach and engagement associated with those services. And we have a phased rollout for these services in Oregon, and we're still very early in our implementation. So climate services, which include devices like air conditioners and air filtration devices, rolled out first, beginning March of this year. At the same time, qualifying members could start receiving outreach and engagement services to help connect to those climate services and other services within the state Medicaid program and other agencies. And we're on the cusp of the housing rollout, with this benefit launching in November of this year and covering services such as rental assistance and utility support. Finally, our nutrition benefits will start to roll out in January of 2025, covering services such as medically tailored meals and pantry stocking. Next slide. The other important thing in Oregon, and something that greatly impacts our data sharing needs, is that to qualify for health-related social needs services in Oregon, a Medicaid member has to be experiencing a life transition, and they also have to have a clinical and social risk. The qualifying populations are listed on this slide. So for example, being someone who has had experience with the child welfare system at some point in their life, or being someone who was released from a carceral setting or a residential behavioral health setting within the last year. We'll go into more detail about the critical role that data sharing plays in helping us identify Medicaid members that could fall into one or more of these qualifying populations. But with that, I'm going to turn it over to Lisa Parker to talk about how this model impacts our data sharing needs in this demonstration. Next slide.
Thanks, Amanda. As Amanda just outlined, there are a variety of services and population under Oregon's HRSN, or health-related services with social needs demonstration. This results in a large, complex ecosystem requiring coordination and data sharing among various actors such as fee-for-service, managed care entities, our agency, HRSN service providers, carceral and psychiatric settings, clinicians, care managers and case managers, etc. These actors need to know various things such as the status of HRSN referrals and services, social risk, entry and release information, eligibility, housing status, clinical diagnoses, etc. It can take years to set up or modify systems and agreements to allow for data sharing. And so we could talk for hours on this topic, but today we're just going to touch on a few areas noted here on the slide. And a couple of things to note about Oregon's environment are that we have a market-driven approach. So we have no legislation that requires closed-loop referral technology or health information exchange participation. There are contract terms with our Medicaid managed care entities that encourage the use of closed-loop referral technology and HIE. But we allow our Medicaid managed care entities to determine the tools and workflows that work best for their region. Next slide. And now to talk about closed loop referrals. Next slide. I know North Carolina talked about this, but I'm just going to go over that. For our demonstration, CMS has a requirement around closed loop referrals, which is sharing information between organizations to make HRSN referrals and provide an update on the status of the service for Medicaid members. Or in other words, the organization that sent a referral gets an update from the receiving organization on what happened with the referral. Was the organization able to provide the service, and was the service delivered? Next slide. So this brings us to Community Information Exchange, or CIE, which is the term we use in our state to talk about closed loop referral technology. We consider CIE to be where partners in the community are using a shared platform to exchange information and connect people to services. This technology must include the ability for closed loop referrals, a shared resource directory that allows for service searches, and capturing consent to use the technology by the person being connected to services. Users of the same CIE platform with permissions and who share a client can see information related to the person, such as social needs screenings, referrals, services, and contact information so the organization can reach out about the services. Users of CIE include community-based organizations, clinics, local public health departments, social services, healthcare, etc. There are some behavioral health organizations participating in CIE as being both the ones to send referrals to others, as well as receiving referrals to provide services. There are some referrals made to substance use disorder services, but we've heard that mostly those are made outside of CIE. CIE efforts started developing across Oregon in 2018 and have spread over the years, largely sponsored by our Medicaid managed care entities, health systems, and health plans. There are two main CIE efforts in Oregon, which use the vendors Unitas and Find Help. All Medicaid managed care entities are using one of these two platforms, but currently the Medicaid fee-for-service program contractors in our agency are not. So to create parity, we are going through the process to procure CIEs for fee-for-service use in our agency to meet the needs. And we evaluated whether we should use DSHP infrastructure dollars under the demonstration or pursue Medicaid Enterprise System funding, also known as MES or MMIS funding. And our leadership recognized that the community-based organizations that may become HRSN service providers have such limited resources and capacity, and therefore they made the decision to pursue MES funds at 90% of federal match with 10% state match for CIE implementation so that we can give as much DSHP infrastructure dollars as possible to community-based organizations so that they can build up their capacity to become HRSN service providers. We received approval from CMS in March of this year for MES funds to procure CIE technology, but do not anticipate contracts until next year, and so that we can participate in the CIE efforts that already exist in Oregon. Next slide. So over the past couple of years, we have collected input from various partners to hear what is needed to make statewide CIE successful. This included a CIE work group with a report to the legislature, interviews and surveys with CBOs to hear about their needs, and input from our Medicaid managed care entities. We consistently hear about the challenges that community-based organizations face with the lack of resources and high staff turnover, leading to barriers with CIE adoption. These community-based organizations are ones that will become or are now HRSN service providers, and they are critical to the success of our HRSN demonstration. Therefore, we decided to create a phased-in approach for the use of CIE to meet the closed-loop referral requirements where members will always have the right to not participate in CIE. This year and next, Medicaid managed care entities are required to support and incentivize HRSN service providers to adopt and use CIE, but there is no requirement to use CIE. Next year, our agency will begin providing technical assistance, support, and coordination with what our Medicaid managed care entities are already providing. And then we have messaged that there may be a requirement to use CIE in 2026 through 2027, but the decision and details on that are still pending. Given not all providers will be using CIE technology, this creates challenges with data collection, reporting, and analytics. And we're working with our Medicaid managed care entities to collect what we can from CIEs. We're also looking at other data sources to collect information about closed loop referrals and then store that data in an agency data warehouse for monitoring, evaluation, and analytics purposes. I'll now pass it over to Amanda to talk about hospital event notification systems.
Thank you, Lisa. Thank you. So I'm going to talk a little bit about another strategy here to exchange information. In this case, this is sharing data held by the Oregon Health Authority or other agencies with our Medicaid managed care entities, other contractors, and providers. So Lisa just walked through a little bit earlier our various needs for data sharing, and what I'm going to focus on here is one way we're approaching data sharing to help identify members that may qualify for health-related social needs services. First, a reminder that Oregon's program provides health-related social needs for services for individuals that are part of various populations that are in transition, such as those transitioning from a behavioral health residential setting or a carceral setting, or have had child welfare experience in the past. As we build out our HRSN services program in Oregon and our data and analytics strategy, we've really had to leverage existing infrastructure for data exchange, and that's due to the model I referenced in the beginning, as well as time and resource constraints. In Oregon, one of these potential pathways is our existing hospital event notification system. Point Click Care is the vendor, and it houses our emergency department information exchange called EDDI for real-time admit and discharge data, and also our collective platform, which spreads access to this and other data to the broader care continuum. OHA has a subscription to support this platform, and that includes the Medicaid managed care entities, dental care organizations, tribal clinics, Medicaid fee-for-service contractors, and others. And our Medicaid managed care entities have reported using this data within Point Click Care for targeting high-risk populations, including many that face inequities due to racism and other social factors, follow-up after an ED visit, and identifying high utilizers. So during the pandemic, OHA really leveraged this use and leveraged the collective platform as a data sharing mechanism to get vital state held data, in this case, vaccination status, COVID lab results, into the hands of managed care plans and clinics so that they could use the data to support care management. I want to mention here another data integration that has been really critical supporting care management for patients with behavioral health conditions, including substance use disorder. Since 2016, public and private healthcare stakeholders have made significant investments to leverage statewide integration of our prescription drug monitoring program, which we call the PDMP, into clinic and health system electronic health records and systems like Point Click Care. The PDMP is a crucial tool for prescribers at the point of care to ensure that patients are not receiving unnecessary prescriptions for opioids and other narcotics, helping to prevent drug addiction and overdose. So this is a really critical tool for us in the state around care management. We'll go to the next slide. Building on the precedent that we set in during COVID and sharing data using Point Click Care, we are also exploring how Point Click Care can again be leveraged to support health-related social needs services. Later this year, and we're expecting this for Q4, Oregon State Psychiatric Hospital, the Oregon State Hospital, will expand the type of data it shares with Point Click Care in a way that will support identification of potential health-related social needs eligible members. So specifically with the launch of an admit, discharge, transfer data feed from our state hospital, users will really have real-time access to and configurable notifications for encounters of their patients or members at the state psychiatric hospital. And because people discharged from our state hospital may qualify for health-related social needs services in Oregon for 1 year after discharge, you can see how this data will be really valuable for HRSN as well. Additionally, we're considering other ways that we might leverage Point Click Care or other existing platforms to support eligible member identification and care management. And these might be modeled similarly to our strategies to share COVID-19 data shared on the previous slide. So we're exploring how state-held data from other eligibility groups or agencies could be shared via the collective platform in Point Click Care, such as those connected to carceral settings or child welfare or who have complex needs, and give our partners the information to be able to identify members for new services. And in all of this work, we're treading really carefully with the understanding that this information is extremely sensitive. So for example, we're considering how sharing more of a general indicator that someone may fit into one of these eligible populations could help protect member privacy and avoid re-traumatizing members. And with that, I'll pass this over to Steve Westberg.
Thanks, Amanda. Continuing on in that theme and really in that last part of the discussion around what Amanda was sharing around our other state agency partners that aren't involved in health and human services. Predominantly, our data sharing with our systems has generally been one directional once you're outside of the provider or the managed care organization relationship. similar to other states, we rely heavily on our MMIS and 834 file-based transactions. And what we're really working on now is once we start getting into those qualifying populations, we really needed the ability to share data bidirectionally, not only for the eligibility determination, but also for duplication of benefits analysis. So we are standing up a bidirectional, multi-directional data sharing environment, proof of concept, and as Amanda mentioned, taking it slowly and carefully as we roll out so that we can not only be careful around the data that we're sharing, also test out pieces for transforming the data, turning individual specific data into flags or other indicators so that we're sharing minimum necessary, and really streamlining the data sharing agreements across our state agencies that we're needing to share. So next slide. The lessons learned slide. So and really, I think this goes for a lot of projects that end up happening at the state, is really thinking about that planning for the data sharing needs before you apply. So really thinking about that human-centered data informed decision making process and what data you're going to need before you do that application. We did not quite do enough of that discussion before submitting the application. Really going through discussing options with external partners, before the fact. And also similar to what was mentioned earlier, we are taking on this effort as part of our data modernization efforts. So we're using CMS 9010 Medicaid Enterprise System funds to build out this data sharing infrastructure as we go. And similar to any other IT or large data project, really, as you're doing that planning, consider those barriers and timelines related to funding. Oregon has, and I know we're not alone in this, but we really have a long procurement timeline. And also some of the multi-directional data sharing environments are also leading to that need for additional legal analysis and support as we go through and work on sharing data in ways that we haven't shared before. And back to what Amanda and Lisa mentioned, really expect to leverage as much as you can on your existing data sharing infrastructure, and include that in part of your planning efforts as you try to figure out how to navigate moving forward. And with that, I think we're all done.
Great. Thank you so much for your presentation. With that, we will go to questions for the Oregon presenters. Or if you have questions for both presenters, feel free to submit those. As a reminder, you should use the Slido Q&A panel on the right of your WebEx screen to submit a question. So we'll start with one that's come in. What are your strategies for developing relationships and sharing Medicaid data with homeless service providers?
Thank you for that question. So the first thing I'll say is that we're still very early in the implementation of our health-related social needs services. And as I mentioned earlier, our housing services in particular have not yet launched. So they'll launch in November of this year. But the primary strategy we've been using is we've had a very close partnership with our state housing agency called the Oregon Community and Housing and Community Services Agency. and working directly with that agency to understand the complexity of their own data systems, their Housing Management Information System, HMIS, which operates both with some centrality at the state level and also a lot of sort of local and regional control with homeless service providers and housing providers. And so that I would just emphasize that early partnership building early in the implementation process, and that partnership both at the program level and also among data and research staff at each agency has been really critical, because it is going to be a really complex body of work to directly share at the regional level given Oregon's structure. So I think that's what I'll emphasize, unless colleagues Steve or Lisa, you have anything to add.
No.
Thank you for your answer. The next question is, how do you support data standardization without losing context and over-medicalizing HRSN? And I think this could actually apply to both of our presenters if you're interested in answering, but why don't we start with Oregon?
Great. Well, this is a really great question, and I think I'll speak to two strategies just briefly. One is that we've been working with our community engagement teams internally and our agency's ombuds program to really identify how we can gather qualitative data to support the standardized data that we'll be working with. I mentioned my team's going to be doing a lot of the analytics related to these services, and we want to make sure we're combining qualitative and quantitative data sources, so we can really understand the member perspective and also the community partners. The other is that I want to mention is that we are working on strategies to partner directly with community organizations that will be health-related social needs providers or who are already health-related social needs providers. We are still very early in our implementation as I mentioned. So at this stage, this looks like meeting with HRSN providers to help us design the reporting templates we'll be using for required reporting for our managed care entities, and really thinking about how standardization will impact them and their processes. And as we move further into implementation, we are using some of our infrastructure funding to work directly with community organizations, informing our data interpretation, our presentation, ultimately to hopefully build more direct data sharing pathways with communities so that organizations can create their own analyses that are more representative of and useful to their communities. So those are the two strategies I would emphasize.
Okay, thank you. Would North Carolina like to add anything to that? Any thoughts on supporting data standardization without losing context and over-medicalizing HRSN?
This is Kristen. I think in North Carolina, one of the real benefits that we have is a single closed loop referral system across our state. That has really helped to make sure that the data that's coming in as part of our Healthy Opportunities pilot is all kind of standardized, and we have a set of those data across in each of those regions. It's made it a lot easier for us to get the data that we need to do kind of rapid cycle assessments early on in the program, and then ultimately to do the evaluation that the interim evaluation that Maria mentioned earlier during our presentation. Because we had those data that were standardized, we were able to do those comparisons and really compare the pilot communities with Medicaid beneficiaries and non-pilot communities much more quickly than if we had been pulling in data from various sources, had to normalize those data, make sure we cleaned up various differences. And just, I mean, I think to the point that you mentioned is bringing stakeholders together early and often in the process. I think Maria mentioned that as well, is critical. So even for our care management programs, getting input from the field, from local primary care providers and entities providing care management early relative to the reporting requirements that would be required on the care management data sharing side was critical, because ultimately they had to build out their technology tools to be able to report the plans in a standardized way. So getting that information or having that shared conversation and making sure to standardize the expectations was absolutely critical.
Great, thank you so much. In the couple of minutes that we have left, we'll switch gears to talking about the takeaways from the breakout sessions. So thank you to everyone who submitted the summaries of your key takeaways. reviewing the information, I guess what jumped out at me was, one was multiple people noting that states were at a very wide variety of stages of implementation and data sharing, which is not overly surprising. But something else that was also a theme, I think, is that multiple comments focused on how there were common challenges in states, even within a small group of 2 or 3 states or so. Some of the themes there with challenges were about data sharing really taking time to develop plans, difficulty in gathering and aligning data from various sources and agencies, for example, tribal health organizations, and maintaining sensitivity to tribal health needs can be challenging. Other challenges related to maintaining data integrity and operational function. I think one submission summarized it well when said data sharing is politically and technically challenging as well as legally complicated. So it seems like many of the breakouts focused on challenges and common challenges across the groups. So thank you everyone for participating. Thank you, of course, to our presenters. We'll now move ahead. The last slide here. We'd really appreciate your feedback on this webinar. We have a post-event survey. The link is in the chat and also on this slide. It's not going to pop up automatically, so you will need to cut and paste or click. And so we'd really appreciate your feedback on the session, on the breakouts, the presentations, any feedback you'd like to offer that would help us think about further sessions as well. So thank you very much to everyone for joining and to the presenters, and I hope you have a good rest of your day. Thank you.